Okay.
Phone IC tak boleh. What is monitor?
Kita bawa
Telefon mana boleh masuk IC?
ni monitor. Nak access monitor. Ni kita nak masuk kita nak entry. Kita tak bawa monitor.
Alright.
Kita buat round.
Okay, so everyone agree? Semua okay ke?
Ya. Okay.
Ada orang nak credit card ke? Nak bawa
Tak ada.
Okay, so to get into the ICU, number 1, you must know the list of patients who are in the ICU. Okay. Secondly, you want comfortable shoes because you nak lari sini, lari sana, jalan banyak. Okay. Thirdly, you have to be dressed appropriate. Okay. So Malaysians, I think we have no issues. We dress quite well, and but in other countries, they might go in with shorts lah, some mini skirts lah and all that, okay? And then, of course, telephone. You want to be contactable and you want to contact, you want to contact NTRC, you want to contact the lab, radiologists, okay? And of course, ID, very important. ID, because when you go in, people must know who you are, kan? So you have to have an ID card. Okay, good. So you have all the tools to go into ICU. Now you have come in and you are going to start doing rounds. And what are you going to do in the ICU? What are you doing rounds for?
Donor detection.
Yes, you want to detect who are your possible donors, potential donors, eligible donors, or actual donors. Okay, all these patients, you have to go in with the mindset that they are all possible donors.
Okay.
Alright, okay. So bed number 1, come, let's start. So he's a 71-year-old male, okay, Mr. Amos. Okay.
Atrial fibrillation currently controlled with digoxin, laparotomy scar. Main current problem are spontaneous brain hemorrhage 2 days ago, severe intracranial hypertension, GCS of 3, fever since yesterday.
Okay, so what do you think?
Yes.
Serious brain injury.
Is a potential donor.
Sebab dia
GI.
history, so he's a potential donor. Okay. In that history, is there anything that is worrying you? Yes, it's a potential donor. Fever. Okay. So you are thinking of maybe sepsis.
Yeah.
Okay, good. Anything else? Laparotomy. You want to know what the laparotomy was for, isn't it? Okay. It's a PGU. PGU. So is that an issue?
Yes, nak tahu dia punya contamination.
Memang contaminated lah. That's why ada fever.
But it was how long already?
Surgery was very short, 1 hour, 1.5 hours.
Post-op day?
This is post-op day 3. When did he have day 2? 2 days ago. Yeah, so day 3 lah.
Is the patient on? Is he on antibiotic coverage currently?
Yes, he is on.
So you mention PGU, nak tahu causes of PGU, dia makan NSAIDs ke?
Yes, he was on NSAIDs.
Kidney okay?
Okay, so you want to know other things, right? Okay, so let's open the second one. Let's see what clue is there.
Brain death.
I've already done a brain death test. The patient is brain dead already. Okay, so how now? Is this still a potential donor?
Eligible?
Possible donor.
Possible.
Brain dead.
Eligible. Diagnosed brain dead is eligible donor. Okay, good. Now you know that he's an eligible donor. So what are the things you want to
So
know?
nak hantar all the blood investigation, all the imaging.
So let's open the next one.
Donor card.
Okay. Family initiated. Because dah buat brain death test dah. So family has initiated, for donation.
So potential donor lah.
Eligible.
Kena buat conference dah dengan kalau dah family initiated, kalau dah ada consent.
So
It's a
kena contact NTRC.
Possible.
Kemudian
You want to contact terus You don't want to see other things. You don't want to look at other. What else other than investigations?
I think start with the history,
Yeah,
physical
history, that's the
information.
history.
Means any social history, is it suitable?
Social history, what do you want to know?
Yeah, means any high risk,
Oh, there's no high risk behavior.
no high risk behavior.
The sepsis, doctor, whether it's treated, the source of the sepsis.
Alright, okay. So you want to know if the patient is hemodynamically stable.
Stable,
Yeah.
alright.
Let's open. You
Correct.
want to know how bad the sepsis is, right? Okay, so what do you think?
So nak tahu
Septic shock.
sepsis
Oh.
parameter.
Patient is in shock. Okay, so the patient is brain dead and he's got sepsis. Okay, so the shock can be a mixed picture, isn't it? Sepsis as well as the brain death itself can make the patient unstable. Okay, alright, so the patient is in shock. What else you want to know? You said just now the investigation.
Investigation.
Let's open the last one. Okay, so let's look at the investigations. What do you think?
Potassium high,
Sodium high.
sodium high,
Sodium high.
The liver also
Crack
high.
is high.
Negatif.
Liver pun high.
So dia punya
So the mati failure.
Okay, so the patient is in septic shock and multi-organ failure. So what do you think now about this patient?
Probably not appropriate.
Not appropriate for what?
For organ.
Okay. What about tissue?
tissue high,
If we can treat this sepsis, and then maybe we can take the eye. If we can treat the sepsis.
So you only want to take cornea. But this patient,
Or maybe we treat the sepsis and then we see the progression, the improvement of the organ later on.
what do you all think? What the rest of you think?
It's not a good donor.
What do you think? Okay, you think it's not suitable. What about you?
I don't think it's a good donor.
Even for tissues, is it?
It's about yes. So source of sepsis probably not
settle.
identified at this moment.
What about you? What do you think?
Tak kot doktor.
You don't think? You feel?
And the others? Maybe I will give a bit of time to treat the sepsis and then assess control the infection, whether there's a return of the function of the organ.
Okay. And you?
Yeah. One thing I have to deal with the intensivist as well, because first brain death test done.
I'm the intensivist.
Yeah, first brain death test. Normally, the intensivist cannot wait long because after second brain death test, probably they'll go for withdrawal.
Okay. So it's not about the intensivist. It's about the patient. Irrespective of what the intensivist says, it is what is the right thing to do. Okay. So if you were the one in charge of that patient, what would you do?
First, I'll discuss NTRC as well.
Okay.
Get a second opinion.
What is your opinion?
My opinion, if got time, treat. Look at the septic profile. If sepsis parameter improving, and then probably.
So how long are you going to wait? I've done the brain test.
24 hours.
What about you? After starting antibiotics, how long are you going to wait?
I don't know, at least 3 days, but I'm not sure if applicable to this patient.
What about you? What do you think?
I
Nak
think
usik
if
ke?
of patient is in septic shock, I will inform back the family members that currently the condition is not suitable for donation, and in view of sepsis, it might take some time for it to be controlled by that time because patient already considered death, so it's not suitable for donation.
The rest of you agree with her?
Yes.
Okay. Let me say something. Sorry, just get in there. This one. This is wasiat terakhir. Okay, this is the dying wish of the patient, and the family also has initiated. So as coordinators, it is our job, the onus is on us to fulfill this wasiat terakhir. Okay?
I don't know.
So you must try your best. This is actually an eligible donor. I've done the brain dead test. The patient fulfills the gift criteria. The only issue is what? Sepsis. Okay? So sepsis is not a contraindication for donation. Neither is shock. As long as you are able to get an MAP of 65, the perfusion to the organs are fine. Okay, AKI may worsen. Patient may become anuric. It's okay. Because it is acute kidney injury. It's not end stage, it's not CKD. I've done the brain dead test. Is there a problem? Is there a waiting time? There's no hard and fast rule. Nowhere is it written that after your second brain dead test, yes, the cause of death or the time of death is the second brain dead test. But it doesn't tell you when you should turn off the ventilator. Okay? So if you want to treat the sepsis, give the antibiotics, take the cultures before that. Wait for 48 hours for the antibiotics to work and then proceed for procurement. It's not an issue at all.
And it might be already consented. Yeah, most likely they are
What
willing
if
to
the
wait.
culture comes back later as some multi-drug resistant bugs?
It's okay. You've got broad spectrum antibiotic on board. Trace it, inform the recipient team. They will give the antibiotics to the recipient. So what if the patient is anuric? The recipient may be anuric too, but it's AKI. So you can always dialyze the patient, the recipient, until the kidney function recovers. Okay, it's called delayed graft function.
You can always.
Delayed graft function is a common thing that happens even with good kidneys, normal kidneys. It can happen. So in AKI, all the more reason it will happen. But it's okay. The ICU team that is taking care of the recipient will dialyze the patient until the kidneys recover. Alright? Okay? So this patient is actually an eligible donor. So you want to give the patient time because they have initiated, they want to donate. So we should try our best. Okay? Alright, clear about this? Okay, anyone has any question about this patient?
The one with ethical issue, how because the patient is dead now.
Yes.
Patient is dead. So we are maintaining whatever we're maintaining for the organ.
Yes.
I think it's causing more harm because patient is dying inside now.
But it's the dying wish of the patient.
Okay, sama Syamil macam as if we wait for the procurement team to come kan. Ada patient yang bukan sepsis pun because second death confirmed at this hour this morning let's say kan. Tapi procurement can only be done next day because of the logistic of the procurement team. So we continue the treatment because that is the process. So this is also to make sure that it comes to a donation lah.
Currently the purpose is to reverse the sepsis rather than maintaining whatever the condition, right? So kita
See,
purposely
you are doing donor maintenance and you are treating the sepsis. So that the patient and the family's requests can be fulfilled and it will benefit recipients.
in the case of limited ICU resources, limited beds, I don't think it's fair to use that bed just because
That is that question is very difficult to answer in our setting.
yes.
Okay, but there's always a way around it.
I might want to put this perspective that when that donation happens, you are helping another 5 patients.
Especially
Keep that
patient
way.
already organ pledger and already
Because
consented.
consent already ada. Bukan something yang
The question is
approach.
even harder if patient is not pledger or family 50-50 lagi
So
tu
you
sah.
must be very clear with your thoughts. All the other influencing factors like ICU beds and intensivist punya, fikiran, all that is secondary. But you must be very clear on your conviction. This is what is to be done for this patient. This course is to make you clear.
Do we need to consult the family again, explain the current condition?
Yes, of course. Of course, you have to update them because this patient can arrest any time. In spite of you having got the consent, the patient is in shock. So patient can arrest any time. Okay? Which means you may have to do CPR and all that. So you have to update the family and explain to the family again and again why the delay, what is happening with the patient. Because you may, after all that effort that you have put in, you may still not be able to proceed with the.
We also don't want to frustrate the family because family want to donate.
Okay. So your conviction has to be clear that this is what is to be done, and then you deal with the other things. Talking to intensivists. If you yourself are not clear, boleh ke, maybe tak boleh, and all that, then if you yourself are in two minds, it's difficult to convince the next person.
Tak ada
So
orang,
that is
tak ada
what
orang
is-
lain nak fight for that patient untuk hak dia untuk jadi donor.
What's the reasonable time limit to try? 72 hours, 24 hours, or 7 days?
Antibiotics is 48 hours. Okay, so 48 hours
So no
of
response,
antibiotic has-
worsening, you just wait it out, is it?
Even if it is worsening, you can still proceed for procurement. As long as you can maintain an NEP of 65.
At the end of the day, recipient team tu yang akan decide nak ke tak nak. This is, you present the case, this is what we already did, gini, they might consider still. So jangan level kita dah terus kata tak boleh.
Betul.
We do
Yes.
everything, we present everything up to them.
Happens to me in reality. We try our best. Although all the other anesthetists say no, this is gone case. I say no, we go forward. Until the end, nephro 50-50 sampai nephro kata, I think okay, this is good candidate, we take. A lot of problems lah, so have to fight for the
don't
patient.
get disappointed.
Hmm.
When you have a case, you try your best because it's the patient's right. Okay, so you try your best, but if you still, in spite of all your efforts, it doesn't go through, it's okay. Don't get disappointed. At least you have done your best. Okay, so it's not the results that is important. It's not the destination. It's always the journey. Okay.
Family pun akan okay sebab bila kita dah explain this is kita dapat semua. So dia akan faham lah tapi tak boleh nak macam mana. Tapi dia akan tak puas hati lah kalau we don't even try much pun.
You may encounter a problem with the mortuary team, the forensic team. Okay, because in my experience, there was a patient where we did the brain death test and the time of death is on the second brain death test, right? Lepas tu, because it took some time for us to do the procurement and all that, the forensic team actually asked, why is there such a 3-4 days delay? Meninggal hari ini, your death certificate, and then when they came, the body was delivered to the mortuary, it's a different date and time. So that may arise. But we just have to explain. Alright? So clear about that case? Okay, excellent. So that one is an eligible donor. You will come back tomorrow and see that patient again and see how the progress is.
If the patient arrested, then we CPR.
Yes. Do everything we can.
Revive.
If revive, can procure? Can lah.
Okay.
Even with money.
So,
Evaluate.
patient
Donor
feedback
quality
two.
assessment.
71-year-old female, hypertension, type 2 DM. Current problem, spontaneous hemorrhage 5 days ago, severe intracranial hypertension, he says 3. So,
She says 3.
possible donor?
He fits the gift criteria.
Yes.
So is it still possible?
Potential.
Potential donor.
Sorry, potential.
Because you're suspecting brain death already, right? Okay.
Alright.
So let's open the next this thing and see.
I like it.
Yeah, all out.
Very good. Yes.
All out.
Okay. So let's see. Okay, what's the next one?
Oh.
Normal cerebral blood flow.
So how? Is he still a potential now?
Still, we have to wait.
It's potential. It's not brain dead one.
Yes, not yet, but over time.
Yeah. So is it still potential?
For now,
It's
not
possible.
possible. So
It's possible, right? Okay. So you want to see the other parameters to make sure that he's still a possible.
Okay.
Or not.
Oh, okay.
Stable.
Stable.
Excellent. Okay. Next one.
Next one, investigation. HB good.
Sodium.
Sodium normal, potassium normal, crack, no crack, borderline. HIV negative.
Okay, so all good. All good, right? So he's a possible donor lah. So you take him on your list and you want to come back?
Yes, come back.
And see, esok come back to see these two patients.
Dia kerja. Don't get excited lah, he's not dead. There's no approaching that.
So you punya round hari ni buku you possible.
And then the nurse in charge, if any changes, to inform you immediately. Okay, alright, okay. So bed 2, good. Okay,
Okay,
now let's go to bed
56-year-old
3.
male, no medical history, brain trauma, increase ICT, GCS3.
So possible lah.
Possible.
GCS 3.
Potential lah.
Potential, sedation already. Okay.
Brain dead. Diagnosed.
Okay. So that is a TCD. This is also a TCD. Okay. So you look at the TCDs. This one is very good flow, and that one ada flow, but the flow is spiked like that. Okay. So when you have a TCD, you must remember, if they demonstrate no flow, it is wrong. You cannot accept that. Okay, demonstration of no flow actually means that the probe is in the wrong place.
Okay.
So you have to get that kind of flow.
Okay, need to get ratio.
Okay. So looks like branded lah. Bagus. So now it's become a eligible donor. Alright. Okay. Excellent.
Power.
Oh,
So stable.
stable.
Okay.
Hemodynamic.
Very good.
Okay. Next, lab.
HB normal, leukocyte
7,000.
normal, sodium
Sodium okay. Negative. Oh, okay.
Okay. So all looks good. Okay. Great.
7 minutes. Okay.
Apa ni?
So medication, the patient was diagnosed of colon CA 1 year ago, underwent right hemicollapse. Being followed.
One year.
Dah boleh kan? So how many years?
5 years.
So medically unsuitable.
Medically unsuitable.
Okay, next.
23-year-old asthma, keep worsening of asthma 12 hours ago. So ni tak tahu GCS macam mana kan? So
ICU patient lah. So you nak
Macam
tahu
mana
whether
more
it's
say,
SDL.
GCS
Okay lah,
kita.
open now the next one.
Neurological stable.
GCS
GCS okay.
So this is not a case lah.
Oh, round.
Round lah.
54-year-old, cholesterol,
Buku round ada tak? Pada bawah lah.
severe intracranial hypertension. So
Possible.
Okay, so this is a possible.
Is there anything there that you're worried about?
Why hysterectomy?
So you want to know what caused it? Okay, so the hysterectomy was for fibroids. Okay, so boleh lah.
Yeah.
Okay.
Wow.
Bagusnya.
All out.
Okay.
Okay semua patient ini. Okay, brain all again. Diagnosed.
okay, so eligible. Okay.
So eligible. Stable sama.
Okay. Ada isu lain ke?
Issue lain. Investigation. HB, leukocyte, okay, sodium, okay.
Proceed.
Okay.
So it's a
Eligible.
No. Sebab dah consented kan?
Oh, dah consent.
Jadi
Actual. Okay. Finish.
so this one is a 4-vessel angio. You are right. Alright. Okay. So let's go.
22-year-old
The intensity is coming for rounds already.
Chase hours ago, brain trauma 24 hours ago. So nak tahu GCS dia.
Okay.
Finding. So pressure, DCS, my pressure.
Stable. Oh. So no diagnose.
Blood investigation.
Oh, the
Potassium normal.
Tapi dia Hodgkin
Hodgkin.
lymphoma. So
So
diagnose.
I would like to know the HPE if it's already so no more.
Medically unsuitable.
It's a hematological malignancy. So you don't even bother opening the rest.
No medical.
Post-operative sepsis, so nak tahu.
Liposuction.
So nak tahu DCS. GCS.
Oh, donor. Pani tanya donor ada kat. Itulah.
Ulceration, so kena tunggu.
Patient is on
Sedation.
There is a liposuction. So no point lah. Just skip it.
Okay.
69, 69 years old male, chronic myocardial infarction with AF, cardiac arrest 15 days ago, coma after cardiac arrest, GCS of 3, fever and leukocytosis for the last 2 days, arterial hypotension.
So possible lah kan?
Possible, don't
Possible. Ada kad ada. Pleasure nak. Yes, pleasure. Okay, pleasure. Okay. Brain dead. Stable.
Actual lah. HIV positif.
HIV positive.
Dekat Malaysia tak boleh.
So you only dapat berapa? Satu je lah actual donor. That one is a that one is a potential. This one is a possible. Okay, the rest all tak boleh. Okay. So out of the 8 patients, you only have 3 patients. So one actual and then the other 2 you are going to come back and give you again. Alright. Okay. So do not be disappointed if not all your patients.
Detection daily.
Bawa buku update.
Kalau boleh hari petang pun minggu sebab ada punya patient.
So any questions regarding this? If the sodium is 170, can you do a brain death test?
Mari saya tolong. Saya gambar.
How many of you say have to correct this? You don't have to. If it is a secondary problem. Okay? You know that brain death, the complication is diabetes insipidus. It's a no-brainer. That is the known complication. So you do not have to correct the sodium.
So but one of the precondition is
No-brainer.
155, right? So
No,
There's no actual criteria lah.
there's no
Probability.
there's no number nothing. If the cause of the coma is hyponatremia or hypernatremia, then you have to treat. If it is a secondary problem, you don't have to. Same goes to urea. Okay? If the primary problem is a uremic encephalopathy causing the coma, yes. But if it is a AKI, which happens later, you don't have to. The only reason why you may need to dialyze is if the patient is on high doses of midamorphine, which is accumulated, okay, it's got active metabolites, then you might want to dialyze the patient to eliminate that. Or you can even give reversals. Okay, you can give your naloxone or flumazenil, okay, to do the test.
So let's say patient septic shock initially but improving somehow the blood CNS the total white CRP is
Coming down.
It's coming down, but it is coming down trend, but not normal yet. But it's already more than 72 hours already.
Of antibiotics.
Of antibiotic.
Proceed.
Can proceed. So another like the renal on support.
Like patient on end-stage renal disease?
No, patient is acute.
Acute, okay.
Yeah,
acute
acute.
is not an issue. You can proceed.
But for the organ.
Yes?
But we have to stabilize till normal numbers or
No.
not necessary.
No.
It's not a primary problem of the... See, brain death test
Okay.
is only when the primary problem of the coma is due to the derangement. You faham tak? Kalau primary cause of coma is trauma or bleed or any reason, tumor, anything that causes intracranial hypertension, you know the cause of the coma, then everything else becomes irrelevant. The rest is all secondary.
So we let the procurement team to decide either to get
The recipient team. So you do what you need to do. Then the recipient team will decide whether they want to take.
Okay, good.
Yeah, I pernah kidney procured at creatinine 160, 170. Yes, happened.
Despite on HD.
Yeah.
Because it's an AKI. It's,
It's
not
AKI,
chronic,
yeah.
it's not end-stage.
The result.
I have kidney being rejected creatinine 95. Sebab dia ada very bad Acdm, red blood cell, keluar tubular necrosis very bad.
The reason I ask because now in my hospital we have case now.
Okay. See, acute kidney injury is reversible. So in the recipient, if the patient here is anuric, when you transplant, the patient is going to be anuric too. But what you need to do is recognize this as a delayed graft function and dialyze the patient until the graft reverses.
Doktor sekali doktor nak ambil gambar. Doktor sekali doktor.
Ya. Okay.
Ni nak
Sini.
tengok ni.
Aha.
Mana doktor?
Najwa.